So today's training topic turns all around the so-called cerebral autoregulation, and in particular about vasomotor reactivity and its test methods. As you most probably know, DWL offers a full range of CO2 vasomotor reactivity functional testing. So for those who are new, for those who did not hear about autoregulation and their test method. So the question is, what is autoregulation? Well, autoregulation is the ability of the brain to maintain critical situation, meaning that for any reason, it must be sure that the blood flow velocity in the brain keeps within the same velocity, keeps stable. So why is this so important? So there are situations that can happen that the blood flow velocity is rapidly increasing. And if the blood flow is increasing above a certain level, but also if situation happens that the blood flow decreases below a certain value, then that will lead to an under support of the brain tissue. So that means above and below these cutoff value, there is no exchange of oxygen anymore, and there's also no exchange of nutrition. And if this is missing, we all know what happens to the brain tissue. This is what we call a stroke, means that the brain tissue is dying. And the consequences, we are all aware of it. So how can we see if the brain, or let's say the arteries in the brain, still have the ability to react to this kind of critical changes for high and low velocity? That is done, the autoregulation is done by vasoconstricting and vasodilatation of the end arterioles in the brain. And this we can stress the vessel by increasing and decreasing the CO2 concentration in the blood. So these kind of test methods is usually non-invasive and well tolerated by patients. And also it correlates well with the loss of autoregulation. With patients, they are suffering from carotid disease. There are different factors which affect the cerebral blood flow, in this case, velocity. So when we talk in terms of TCD about blood flow, we're always talking about blood flow velocity. And the two ones that is of interest here in this case is the arterial oxygen tension, because the oxygen will lead to a vasodilatation. No, it will lead to a vasoconstriction. And also the carbon dioxide tension, which means that we will have a vasodilatation. So what is it about constriction and dilatation? So in the brain, if a vessel is constricting, then because the brain does not need so much energy. So if the vessel is constricting, means that blood is kept out, so not less blood will enter the brain, and this is because of there is not so much energy needed to keep the brain tissue working. So that means in case of a person is sleeping, then we don't need so much energy, or it's resting, or any other condition that will lead to less energy support. So in this case, to reduce the energy to the brain, the vessel can constrict, and that will reduce the blood flow velocity inside of the brain. So the other way around, if someone needs more energy because it's active, it's making sports, it's practicing something, it's working, someone has to think a lot. In this case, more energy is needed. And if more energy is needed, so the vessel will dilate, and that means that more blood will enter the brain and will make sure that the energy is provided to the brain tissue. For the test methods that we are going to introduce to you, these tests working with 2 or maximum 3 test periods. And the first period that always appears in one of these different tests is the normal breathing. That's what we call baseline, or in terms of vasomotor reactivity testing, we are calling it normocapnia. The second test period always is looking at the vasodilatation, so the ability of the vessel to dilatate, to let more blood in. And this is done by increasing the CO2 concentration. This test period is called hypercapnia. And in some of the tests that you will see today, there's also a third test procedure needed. And that means that we have to decrease the CO2 concentration. And this is mostly done by hyperventilation or forced breathing. And in terms of testing, this is called hypocapnia. Here you see the vessel, and the vessel changes due to the O2 CO2 concentration in relation to the concentration in the blood. And with normal breathing, normal condition, normal breathing addressed, we have a specific diameter of the vessel. And if we increase the CO2 concentration, which will lead to a vasodilatation, what happens is the vessel is dilating, the diameter becomes bigger, more blood enters, it's faster, and you will see an increase here in the Doppler signal, a velocity increase in the Doppler signal. So, and the other way around, if we decrease the CO2 concentration, which is then based on a vasoconstriction, means the O2 concentration at the same time is increasing. So in that case, what we will see in the Doppler signal is that the velocity is decreasing. So this is the baseline, the normal breathing. So this is the one that we compare with. Then the CO2 increase, an increase in velocity, and the CO2 decrease, the decrease in velocity. This is what we are looking for. And in normal cases, we will see definitely this increases. And in case of pathology, for instance, if the arterial wall is very stiff, in this case, you will probably not see changes during the different test periods. So what is the benefit of doing this test? Who will benefit? So first of all, this is used to evaluate patients who are having a 70% carotid stenosis, internal carotid stenosis, or maybe higher of this, and sometimes an occlusion. And in this case, if the reserve capacity is exhausted, that means that these stenosis or this occlusion definitely have to be treated, maybe most probably on a surgical way. It's also to identify patients who might, in this case, benefit from a EC-IC bypass or prior to cardiac surgery, to see if this person is having a higher risk during anesthesia. Also to see who of these patients might benefit from a extracranial bypass surgery, and also if you people have with low blood pressure, that if they are on risk for ischemia. Of course, there are also some contraindications, and later on you will see that we are showing you 5 test procedures. And in the past, historically, there have been many test procedures, more different access, trying to look for the reserve capacity. And the reason is that depending on the patient, it's not always possible to use only one of these test procedures. So we have people with brain injury or after subarachnoid hemorrhages. And if we would do, for instance, a breath holding or a hyperventilation, that would most probably lead to rebleeding of this kind of injury. So that would be a contraindication. Also, if a patient has severe lung disease, of course, they will not be able to do a breath holding test, or they will also be probably not able to follow the breathing procedure as given by the test protocol. If people have cardiac diseases, then also hyperventilation would be contraproductive to do this. So it's always important that the user, the doctor who wants to do the test, is carefully looking at the patient's history to see what of the test procedures can be used to look for the reserve capacity. So here I have a table with the most used ones, the ones that became so-called standards, more or less standards. And as you can see from this table, each of these tests has advantages and disadvantages. And again, so the doctor, or let's say the user, whoever is doing the test, need to be carefully see about the patient's ability and the requirements, and then to see what kind of test procedure would be best for this situation. The ones who already know our QL software, they know, and also of our Doppler systems, they know that we have CO2 module. That means that for this kind of tests, in some cases, we need the end tidal CO2 measurement. And to do this, we also need a way to increase and decrease the concentration so that we can see what is the end tidal CO2. So looking at the literature, looking through different test procedures, we find different possibilities to increase the CO2 concentration. So we have, for instance, test procedures, they're using carbon gas, 5% or 6%, predefined gas mixtures to be used for this test. We have simple tests that patient only should hold the breath. People who are not conscious or not able to follow instructions because of their disease what they have or what they are suffering so far. So in that case, this is done on a chemical way using a drug called acetylcholine. And also there are some test procedures using so-called respiration sets, and this is an example. So this kind of equipment can be used from anesthesia supply. So we know now how to increase the CO2. How can we measure CO2? So CO2, or let's say for that formula, we need the entitled CO2 calculation. And therefore, we have our systems, we have the possibility to, via analog input, we can connect a capnometer. That can be done for all of our systems, but especially that will be probably done by the MDT and also the Doppler box. And for the MDX and the MDT, we have also the option to a built-in internal CO2 module. So when do we need a CO2 module? That's for the first two tests, the so-called CO2 reactivity test using regression analysis, and then also the simple test procedure, which is called the normalized CO2 reactivity test, or short NCR. The other tests are only done on the change in the blood flow velocity. So therefore, for the rest of the tests, we do not need a CO2 module. So what is the QL offering us? So what kind of tests can we do? Currently, we have 5 test procedures that can be used from the user, so that can be done. So we have many possibilities to get the best test for each patient situation. And I would start right away with the so-called CO2 reactivity test using the regression analyzing, or this is what would be described in the literature as the golden standard. Golden standard because the test is described in a way that it is reproducible in a specific way, and also because we have the CO2 entitled CO2 measurement, this can be really compared. So this is someone, and also the normalized one, which will be next. These are the ones that can be really reproduced and compared in a proper way. The other tests, more or less quantitative information, and sometimes it's not really necessary to have the absolute value, but to have an idea about what is about the reserve capacity working, or is it rather working, or probably pointing more to being reduced or exhausted. So again, let's go back to the CO2 reactivity test using the regression analysis. And for all of the tests that you can do here, and also because it's a monitoring test module, most important, it's always, and that's why we had the first presentation with the fixation sets, monitoring fixation sets. Most important, it's always that we first find the correct setting of the helmet, whatever helmet you use, the optimal for the situation, the optimal for the patient, that we find the MCA and we fix them in a proper way. As soon this part, this is half of the rent, let's say in a German way. So this is the half of the test that makes it successful. If the helmet and the monitoring probes are fixed in the proper way, the rest of the test is quite simple. So after setting the monitoring fixation, we are starting with record on the software, and then we let it run for a couple of minutes, and the patient has to breathe normally. So for the test protocol, we need approximately minimum requirement 2 to 3 minutes of normal breathing during using room air. Then here we need 1 minute of hypercapnia, means that we have to increase the O2, the CO2 concentration, and these tests usually using a CO2 predefined O2 CO2 gas mixture with 4%, 5%, or 8%. What would be best? So this is depending on the paper you are using, or the user is using, which reference paper is using. So also, if you look to the literature, there are different suggestions for CO2 O2 gas mixture. Alternatively, this can be done by using this respiration system, means that you have a mask and you have one big 10-liter bag or 2 smaller bags. And what's happening is that the patient has to breathe in and out his own breath for about 1 minute. And in this case, the CO2 concentration will increase. So after 1 minute, we let the patient breathe normally. So we disconnect the respiration system, or we stop or disconnect the CO2 O2 gas mixture bottle and let the patient breathe normal again to let him stabilize his normal blood flow. This for a couple of minutes, and then we do the third test period. That means that the patient have to do for approximately another 1 minute a hyperventilation in order to decrease the CO2 concentration and increase so therefore the O2 concentration and force the vessel to constrict. After then, patient can breathe normally again. So either you stop straight away after hyperventilation or you just let it run just in case for another couple of minutes. And then you can stop and start with the evaluation. So with the evaluation, we need from each of these test periods, from the steady state, from each of these, the steady state, 2 or 4 cardiac cycles for the formula. So the formula, as given from here, will then display it in the QL software with the regression. So because it's the regression analysis, and so we'll get here the regression, and we will get here the value in percent per millimeter mercury. So what is normal? What I can find in the literature is that Ringelstein and Widder, that they say that an increase from 3 to 4% in tidal CO2 would be normal. And so again, if you look to the literature, if you are using one of these papers as reference, you have to follow exactly the test procedure as given in the paper, as given in the literature, in order to compare normal. If not, if you do just one single thing different than described, then also the normal value, of course, will be different. And therefore, it's always important to create lab-owned norm values by continuously repeating always the same test procedure with normal volunteers. So looking at the QL software, how can we create our CO2 regression analysis? Quite simple. We reload the file, the recording to the user interface, and we are using the mouse to create 3 test periods. We are looking, so first we are clicking to the trends, highlighting this, what we need for the measurement. Usually it's the mean. So then we can follow with the cursor. So here's the cursor. The cursor always gives us the number of the value, and then we create where we see what is the steady state. We create a rectangle with 2 to 4 cycles. So now we have an average value of normocapnia. We will do the same for the steady state of hypercapnia. And then again, we do it with the steady state of hyperventilation, means hypocapnia. And if we have selected the 3 cycles, we simply press reactivity, and then we will get this box filled with our result. So, just a second. So this is our user interface. We have the monitoring record. We have here the whole monitoring record. Let's see. So we have here the full monitoring record. We have here the trends, and what we need is the mean. So here's the left mean. I have highlighted this. And now I'm looking with my cursor. So we have here the marker set for normocapnia. So starting from here. And now I can look what is a stable mean velocity. And if I'm going through, I would suggest around here, maybe that looks stable. First test period, then I'm going with my cursor to look for the steady state of increased CO2 increase, means hypercapnia. So I'm looking here. So here, and then I'm looking for the minimum. Have here also average one, and then going to measurement and reactivity, and got here my result. Good. That was the CO2 reactivity test. If you look to the website, we have on the Mediathek in the media library, we have now the Doppler Atlas where you can find some references, but also we have created a new chapter with literature, and there also you can find literature referring to CO2 testing. So you can have a look there what kind of literature can be used for this kind of test. So the second test that I would like to introduce you is the so-called normalized CO2 reactivity test. And basically, it's the same than the previous one, than the CO2 reactivity using regression, but not as a regression test. So it's also just using, and it's only using 2 test cycles. That means we are looking at the baseline and we are looking at the steady state of increased CO2 concentration. So here you can see from one of the literature books, you can see an example. So we have here the cerebral blood flow. We have normal capnia. We are selecting a couple of normal cycles, and we are selecting a couple of cycles from steady state of hypercapnia. And then we are using our measurement tool and then getting also a kind of result. Again, test protocol is the way that we are doing a monitoring, looking for a stable fixation. We let it run for a couple of minutes with normal breathing, rest period, and then we increase the CO2 concentration using a respiration system or carbon gas to do the hypercapnia. And we are using cycle of normal capnia. We are for the evaluation and a couple of cycles for hypercapnia. And then you get, therefore, the normal values as described from Berlit and Daffertshofer. So in this case, you can see that you get different values. So normalized CO2 testing is with this form given with this formula inside of the QL software, and you select only normal value and normal breathing and steady state, and then you press the right button. Again, here the QL software, we reload our file. We looking for normal. We select first the trend that we want to measure. We select some cycles of normal capnia. We select some couples of hypercapnia, and then we press NCR. Also, therefore, you will find a couple of references in the media library. So let's see how this is looking like in the QL software. Where is my QL? So since we also need the entire CO2 and entitled CO2 calculation based on the formula, so it will more or less looking the same, but not using the hyperventilation part. So again, we are looking here for steady state of normal ventilation, normal breathing. Select this. We are selecting then here a couple of cycles from the steady state of hypercapnia. And then to start the calculation, we press NCR. And then you get here the measurement in percent. Good. That was the second test that can be offered with the QL software. But we are still having some more to offer. And the next test, which was very popular because it's more simple in some cases, it's the so-called VasomotorReactivity test that became the golden standard after Ringelstein. So this is also called the Ringelstein method. And here we also need to increase with carbon gas, with different carbon gas, but it's only measured by looking at the increase of the blood flow velocity, of the mean velocity, not using the entitled CO2. Here I have an old example back to the beginning of Ringelstein's researches. So we have here a Doppler spectra from a normal patient, and this is done with room air, and you see here a specific velocity. So this is the baseline to compare, the base to compare. And then here we have the test period after 2 minutes of CO2 increase using a predefined gas mixture. And here you can just see on the image that here we have an increase in velocity in comparison to the baseline. Here we have the same situation, but on a patient who has an abnormal response. And if you look to normal air breathing, and then after 1 minute of CO2 increase, and also after the second minute of CO2 increase, you do not see a change. And that means that the vessel wall is not able to dilate. So it's stiff, and most probably this patient will have arteriosclerosis or kind of stenotical processes, which then leads therefore that here the exchange, or let's say the regulatory part cannot happen. So how can we perform the test, or what is the examination protocol? Here we are also doing normal capnia by normal breathing. Then 1 minute of inhalation of the carbon gas. So the Ringelstein method is done with carbon gas. And I think he used 5 or 6%. That's due to his reference. Then we have again 2 to 3 minutes normal breathing to let the patient relax and come back to a normal condition. And afterwards, we will look at hyperventilation area, or let's say forced breathing. And then we do the same evaluation step than before with the regression analysis. Do it to Ringelstein. We get only VMR expressed in percent, and what is normal should be above 60%. Everything above 60% is supposed to be normal. So the interpretation here would be if we have a reduced VMR with the Ringelstein method, then we have between 96 to 39% increase. Severely reduced 38 to 16%, and exhausted would be if we are looking at less than 15% increase after stimulation. So this formula is given like this. So this is the one that is also inside of the QL software, and we selecting our cycles in the trend as given before with the regression analysis. and we get our result as an increase in percent, VMR increase in percent. So in this case, let's say we have a different file. So we have the VMR slope. And here you can see that we have not used entitled CO2. So we have here a normal capnia, and we are looking also for a stable normal breathing, and creating a rectangle means that we have an average, but using the mean and not the max. So it's always calculated in mean. So we get here an average mean that will be used for the formula. Then we go also to the steady state and getting also then a mean calculation, which will be used. And when we are looking for the hyperventilation and for the measurement, to start the measurement, we are pressing on VMR. We are getting the increase of percent. Here in this case, we will look if this would be a real test case, which it isn't, it's just an example, just used as an example. But here we would look on reduced VMR. Okay, so what is next? There are simple ways to do that, more simple ways to do that, because here we need different materials. Here we need respiration systems. We need internal CO2 modules, external CO2 modules. We need carbon gas. Carbon gas for patient, for instance, in Germany is not even available anymore because there is no permission anymore to use it on patients. It's only can now be used for calibration, but not for patients anymore. In other countries, probably that's not a problem. So you see, sometimes it appears difficulties. And also, if you're looking on respiration, the respiration system, what was sampled by anesthesia supplies, that because of the new MDR, new regulation, that not all of the pieces are nowadays available anymore. So that can become quite difficult. So in that case, if people do not have all of the material that has to be would be needed for this kind of tests, we can do the simple way. And the simple way is that we just look at the increase between normal baseline and steady state of hypercapnia, and just as a rate of change means that we are looking at the increase of velocity in percent in comparison to the baseline. There are two stimulation that can be used for this simple test. One is the DIMOX, which would be more reproducible, would be more reliable, and also that would be mostly used for patients who are not able to hold breath. And the apnea test is actually a kind of breath holding test. And also with the apnea test, there are different possibilities, different way and different formulas to do that. The good thing is it requires not really patient compliance. But the bad thing is it's at least the apnea test is not really reliable in that case. DIMOX test would be then the better solution to look for more quality information. So starting with the DIMOX test using a chemical drug, For the test procedure, what we need here is that, of course, we need to set up the monitoring. We need to start the CO2 module, on the CO2 module, the software for this test procedure. The doctor has to prepare the patient for the injection, and then as soon as the doctor starts to inject the Dymox, then a marker has to be set, and then the injection has to be done very slowly, very, very slowly, and then the examination has to be recorded for approximately 5 minutes, or let's say for 5 minutes, in order to have the correct test information. The apnea test, meaning different ways of test using breath holding, means that the CO2 is in the blood concentrate, the CO2 concentration in the blood is forced by breath holding, and therefore also you have to be very careful, because the velocity inside of the brain can change, not only because of the CO2 increase. So if people do a kind of Valsalva when they are holding breath, means they do a deep breath in, that will create also a pressure to the breast, but also it will increase a pressure in the intracranial. And so in this case, if the patient is doing this kind of maneuver, making a deep breath, then it's not reliable. The result is not really reliable. So what needs to be cared for in this test is that people just simply holding the breath and not doing a deep breath, just like stop breathing. And then they should breathe for at least 30 seconds, which is not for every patient possible. So also that becomes quite difficult to do. So the examination protocol is the same, more or less the same, or let's say the evaluation. So we are looking for 2 to 4 cycles of normal breathing, and we are looking for 2 or 4 cycles of the steady state. Same for the apnea test. And then looking on the trend, we are selecting with the rectangle a couple of cycles of normal breathing, and we are also selecting a couple of the steady state from the hypercapnia. And then we are using this button to start the calculation with the formula. We get a simple, the result is simple as an increase in percent. Regarding the interpretation for Dymox, I found with DWL and Berlit, I found normal values should be an increase of about 40%, supposed to be normal, and a pathologic low limit would be approximately 10 or less than 10 if you get this value. As for the apnea interpretation, I was searching a lot in the literature. I could not really find references for these values. So if people want to do the apnea test using this test, they should create their lab own norm values. So looking to the website, looking to the media library, also you can find the references, the literature and the references there in the literature list, but also you will find useful information in the Doppler Atlas. So the same test as described here can be done, but instead of doing a simple rate of change, this can be done with using regression analysis. or we in the software we call it slope. So you do the same thing, you do the same test procedure. You are looking for normal breathing and steady state of hypercapnia, and then you are using the slope. And that means that you get here a regression. And the regression then will be described in increase in percent per minute. Also looking at the literature, I could not really find references. So if people like to use this, they should create their lab over normal values. So let's have a look on the software. So for the rate of change, you have here the test, you have here the mean. So we select the mean. We look for steady state of normal. That would be now for the rate of change. And you look for the steady state of hypercapnia. And then you're clicking VMR and getting the increase in percent. And in comparison to the regression, now it's important that you exactly know when the person stopped breathing. So that would be the start for the regression. So you go to the marker where the person really stopped breathing from here, and then you go to the marker that the person started breathing again. So that's important. You go not to the steady state, you go to the marker that was set when the patient was releasing, and then you press slope, and then you get the regression analysis here. So that will be expressed in percent, the increase in percent per minute. Okay. So actually, also literature can be found in the Doppler Atlas and also in the literature lists on the website. Or if you need further information, you know that you always can count on me. I'm here for you to support you with needed information. So when to use CO2 vasomotoric test procedure? So there are many good reasons as pre-surgery cases. During surgery, you can look for reserve capacity, but also afterwards to see if the patient has benefited from treatment. And seeing this presentation, I hope you can see that it's not so difficult to do that. All what you need to do is to know how the test is going and what to do, in which way to perform. So everything is simple if we know how to do. So thank you for listening. I am again at the end of my presentation, and I hope you enjoyed it this time again. And well, I have recorded this, and so you will be able to find this soon